I hope you understood the previous part of the lecture. We will continue with the periapical pathosis. It's a consequence of pulpal necrosis when the irritant reach the periapical tissue. Will depend upon the severity of her irritation, well, duration, and the host response. It will be either acute or chronic. The normal apical or periapical tissue shows no sensitivity to percussion or palpation, as well as the lamina dura appear intact in the radiograph. Once the tooth respond abnormally to percussion and it was sensitive, that means it reached the periodontium. If there is any radiographic changes, whether widening of a lamina dura, interruption of a lamina dura, radiolucency, that means it reached the periapical area. The first type is symptomatic apical periodontitis, or what's known as acute apical periodontitis. It's the first extension of a pulpal inflammation to the periapical area. It might be a sequel to irreversible or necrotic. According to it, the signs and symptoms. Usually, it's a sequel of an irreversible. It's characterized by severe pain. Here, the pain will be localized, so I will be able to differentiate it from the irreversible pulpitis. It's sensitive to percussion, to palpation. There is a positive response, vitality, low grade, or negative in case of necrotic. It's tender palpation, but with no swelling. A tooth is immobile, usually radiographically intact lamina dura, but in later stages might show widening of a lamina dura. This is considered a nightmare for the dentist because in this case, it's difficult to control the pain. There is a depth of anesthesia is a common problem. So if I recognize and distinguish the case is an acute apical periodontitis, I should tell the patient about this scenario and might give a patient a systemic analgesic before the visit. I need to give an intrapulpal or intraligamentar or even a block anesthesia to ensure potency of an anesthesia and profound anesthesia. Well, unfortunately, I have to complete exacerbation of the pulp up to the periapical area to be able to reduce or to relieve the symptoms. But the treatment, as I mentioned, root canal treatment or extraction. Asymptomatic apical periodontitis or chronic apical periodontitis, usually sequelae result from acute apical periodontitis or pulp necrosis. Histopathologically, it's the periapical granuloma or a periapical cyst. Clinically known as chronic apical periodontitis or asymptomatic apical periodontitis. That means it's a granuloma or periapical cyst. I cannot distinguish it clinically from the clinical signs and symptoms. Usually it's painless or slight discomfort. Even the percussion might show no tenderness or slight discomfort. I can distinguish it from the pulp necrosis by increased mobility. There is a swelling in the apical area when I palpate the area, and it might give an eggshell cracking in case of a periapical cyst. Negative response للvitality the confirmatory test is the radiographic features, which will range from interruption of lamina dura to well-defined periapical radiolucency. And I should remember, well-defined periapical radiolucency, that means chronic or asymptomatic apical periodontitis. And I will tell you why later. Treatment, root canal treatment, or sometime I might need a surgical removal of the cyst and episectomy. And root canal treatment with or without episectomy. Acute apical or periapical abscess. It's an inflammatory reaction للpulpal infection. As signs with symptoms are the same as the acute apical periodontitis and irreversible pulpitis. From the symptoms of the patient, our pain history, I might put them in the same category. Differential diagnosis, irreversible pulpitis, acute apical periodontitis, acute apical abscess. Once there is tenderness with percussion, palpation, that means it's either acute apical periodontitis or acute apical abscess. The acute apical abscess characterized by swelling of the oral mucosa, which will be, there is redness and hotness of the mucosa opposite the periapical lesion. This is in case of localized abscess, or it might be generalized in the form of cellulitis. The patient will come to your clinic with a huge swelling at that site. In this case, this is an acute apical abscess, either in the form of cellulitis or localized, localized swelling with the signs and symptoms of the abscess or inflammation, here redness or hotness, together with the severe throbbing pain, and here signs and symptoms of the pain of irreversible pulpitis. The patient will feel fullness or elongation of the tooth as it's surrounded by the pus. There is a systemic manifestation, might experience fever, malaise, loss of appetite, lymphadenopathy. في early stages, there is, it might be no swelling, no localized swelling. With time, it will be localized. There is slight mobility, and swelling might, when palpate the localized swelling, I will feel a fluctuant swelling. Radiographically, lamina dura is normally intact, but if in later stages, it might show widening of lamina dura. Usually in acute cases, there is no radiographic changes, but in the chronic, because the radiographic changes with bone resorption takes a long time. So it's associated usually with the chronic cases. And treatment is root canal treatment, and the first management is to drain the pus to relieve the pain. And first method of draining through the access cavity, through a root canal treatment. Sometimes I cannot communicate with the abscess through the cavity. In this case, I need to do incision and drainage. These are photos of a cellulitis. Here, a localized inflammation. Finally, chronic apical or periapical abscess, what's known as suppurative periapical abscess. As the pus found a way to be released from the cavity through a connective tissue, stroma, and a sinus tract, in this case, it will be asymptomatic. There is little or no discomfort. we can put it in the category with the pulp necrosis, chronic apical periodontitis, chronic apical abscess. 3 of them asymptomatic or slight discomfort. In case of chronic apical periodontitis, I can distinguish it from the abscess or the necrotic pulp with the radiograph. It might show a well-defined radiolucency. In case of an chronic apical abscess, during examination, I will see a sinus tract. The patient might experience a salty taste due to the seepage of the pus. Radiographically, the radiolucent area will show ill-defined radiolucency around the apex. This will differentiate it from the chronic apical periodontitis اللي هو cyst and granuloma. Treatment, root canal treatment, I don't need to drain the pus because automatically it's drained through this sinus tract. في additional periodicular terms, there is an apical scarring due to the inflammation. The inflammatory process lead to proliferation of dense collagenous connective tissue in the bone near the apex. We will see with a distinctive radiolucent presence, dense radiopaque area, or cellulitis. In case of an apical abscess, it might spread and reach the facial planes. Or finally, condensing osteitis or osteosclerosis. In chronic cases, chronic inflammation will induce an osteoplastic activity, will lead to deposition of bone instead of bone resorption. Instead of finding a radiolucent area, we will find a radiopaque area, as we can see here. Thank you for listening, and I hope I was informative and you will be able to differentiate between a different type of pulpal and periapical disease. I know it's a little bit confusing, but to be able to differentiate between them properly, we should be able to put each group together and see the keywords to differentiate them. As I mentioned during my lecture, or my presentation, that usually I should differentiate the acute cases together and the chronic cases together. Inshallah, in the future lectures or live sessions, I will prepare different problem scenarios, and I will let you to interact with me to be able to distinguish and diagnose such a case. Because definitely, when you are in clinic, the patient will not come and tell you that I've got a reversible pulpitis or acute apical periodontitis or whatever. You have to solve the problem. From the history, you will have a differential diagnosis, or you might be lucky. From the history, you will be able to distinguish or to get the definitive diagnosis together with a signs from the 6 tests you will be doing, اللي هو inspection, palpation, percussion, and pocketing, radiograph, and vitality. Together with the history, you will be able to reach the definitive diagnosis, inshallah. Thank you for listening.